everyone. I think we're going to go ahead and get started. We have a lot of information to cover today. Thanks so much for joining us. We're so glad that so many of you are joining us today. My name is Julie Didkowski, and I'm one of Skyland Trail's six now referral relations representatives. I live in Atlanta, not too far from the Skyland Trail campuses. And before we get started, I'd just like to tell you a little bit about Skyland Trail. I know many of you are familiar and know that we are a nationally recognized nonprofit mental health organization based in Atlanta. We specialize in treating adults and adolescents who have a primary mental health diagnosis, and we do so through our residential and day treatment programs. Our adult program treats ages 18 and up. We have 4 psychiatric recovery teams, all evidence-based. CBT, intensive DBT, meaning it's a DBT adherent program. We also have first episode psychosis and cognition, as well as social integration. We offer a co-area focus in dual diagnosis for individuals who are in recovery from a substance use disorder. Our adolescent program treats teens ages 14 to 17 who have a primary mood or anxiety disorder. We are also now treating primary trauma, as you'll hear a lot about today, PTSD. And we also see a lot of kids who have a history of self-harm. Additionally, we can work with kids who have some mild to moderate secondary substance misuse. Most of our programs are in network, with most private insurance as well as TRICARE East. As a nonprofit, we do offer some need-based financial assistance to help families to be able to afford cost. I do want to give a brief update in terms of entrance into and admission to our programs. Clients, whether they're coming into adult or adolescent treatment, can enter into residential treatment directly or PHP day treatment directly, depending on what's most clinically appropriate. So thank you so much. We do have some information on our website at a ton of information actually at www.skylandtrail.org. And it's now my pleasure to turn it over to Molly Mercer-Dedman, our Director of Education Outreach. Thank you so much.
Hi, Julie. Thank you so much. We are in a Zoom webinar, so everybody is able to see the presenters and you'll be able to see the slides, but you're not able to see each other. I see a couple questions coming in on the chat about that. So that is good. We have everybody in. It's taking participation data as we speak. All right, so let's go over some housekeeping notes before we start. So to earn continuing education credits, you must attend the full duration of the presentation. After the event today, you're going to receive a personalized link to your attendee dashboard. That's how a lot of you got on today. This is going to be hosted on the CEGO website. On the CEGO dashboard, you're going to be able to complete the required evaluation form, and you can download your CE certificate immediately. Again, it's a Zoom webinar, so please use the Q&A feature to submit questions throughout the presentation. Caitlin and Dr. Rothbaum are going to reserve time at the end to answer as many questions as possible. Zoom also allows you to enable closed captions on your own screens, and so feel free to turn on that feature if you'd like to. Also note that the slides will not be distributed today, but a recording of the presentation is going to be available next week on both your CEO dashboard and Skyland Trail's website. And again, we can't see any of the participants' videos, but we're able to track all of your names as being in here today. And you can engage with the you can engage with the speakers through the Q&A. All right, so I'm going to go ahead and introduce Caitlin Connolly and Dr. Alex Rothbaum. Caitlin is a licensed clinical social worker and a certified prolonged exposure therapist. In addition, Caitlin is a trained PE consultant through the Emory Healthcare Veterans Program. She is currently the Director of Clinical Services at the Skyland Trail Adolescent Campus, and she has experience in community mental health, corrections-based mental health, trauma-focused care, treatment for co-occurring disorders, and mental health in various education settings. Dr. Alex Rothbaum is a researcher, educator, and clinician with a focus on translational approaches to better understand and develop interventions for trauma, PTSD, health disparities, and social determinants of health. Dr. Rothbaum is Director of Research and Outcomes at Skyland Trail, and he's also an adjunct assistant professor at Emory University. He received his PhD in clinical psychology and Master of Public Health in Population Health Research from Case Western Reserve University. Dr. Rothbaum has clinical experience in hospital, intensive, and outpatient settings, providing evidence-based psychotherapy, and has been trained as a prolonged exposure or PE consultant. All right, Caitlin and Dr. Rothbaum, I'm going to pass it over to you.
Thank you so much, Molly and Julie. We're so excited to be here, so excited to meet you all. I'm Alex, as Molly mentioned, and then I'm going to turn it over to Caitlin to start.
All right. Hi, everyone. I'm Caitlin. We are so excited to have you guys here today. I know that it is a chunk of your Friday afternoon, and we are just so passionate about this topic and so excited to reach so many people to share the wonderful information that we have today. So yeah, let's kind of jump into it. We do have a lot of really great information, but we also know that sometimes these presentations can get a little drab. So we're going to be using Slido. If you guys have not used Slido before, it's a really fun way to kind of get you guys involved and get you engaged in the discussion, kind of see where you're at both professionally as well as it relates to trauma-focused care for adolescents. So all you need to do is scan that QR code, and I believe you can enter that code there. You can also go to slido.com to join as well. It should be pretty simple. So yeah, just take a moment and then we'll walk you through kind of what happens. I believe they should just get it. It should just go right to our assessment, right, Alex? Yeah.
Yes. If you scan this on your phone camera, it'll go right to your assessment and join our CE today, or you can do it on a computer web browser.
Absolutely. And then if at any time you do need that information, you can put it in the Q&A or the chat, and Molly can also give you that code if for some reason you lose it. So if you just want to try that out, we'll give you 1 minute and then we'll kind of get going so we can jump into the information. Yes. So we will start the polls in just 1 minute. We just want to make sure people are getting signed in. If you can't join, that's okay. You can put it in the chat. So we'll go ahead and do our first Slido. The first one, we just wanted to kind of get some feedback from you guys about who all is here today. So you should be able to access the poll now.
Right, and we have a warm-up question.
We have a warm-up question.
It's silly, but you can still scan the QR code to join if you haven't joined. We're just getting everyone used to it.
It's actually very serious. But yeah, this is just so you can get a feel for what Slido does, and just kind of how it's pretty user-friendly. But if you're having any issues, like I said, just feel free to use the chat because we want to make sure everyone's able to kind of participate, even if it's in this webinar model. So as we can see, this is a loaded question. Yes, Beyonce was the best choice for album of the year. But now we can kind of dive into who all's here today. Is everyone, are we?
Well, it looks like we only have 169 people, 170 who voted, so we'll make sure everyone is on Slido till we get
Okay,
to
good
our
idea.
participants. In case some people still need time to join.
Awesome. I'm glad it's working now for you guys. A little fun fact about Alex is that he is a passionate Beyonce fan. So this was his warm-up question, but I fully support it. So not only is he a trauma expert, but he's a Beyonce enthusiast.
All right, it looks like we're slowing down, so I'm gonna go ahead and move to the next one. You'll still be able to join as we go forward.
All right. So this one is going to be a fill in the blank for you guys. We just want to know what state you're from. We're excited that we have so many participants. Right now we have 269 people on, and we just are excited to see who we have here and where we're getting this information out to. Oh, wow. So obviously a lot of Georgia. We have Virginia, Tennessee, Ohio, South Carolina, Washington, D.C., Michigan, Louisiana. Iowa, but you live in Tennessee. Okay, so we're cross country here. Rhode Island, Alabama, Wisconsin, New York. Oh, this is so exciting. You're in the UK. Oh, wow, this is fantastic. There are people from all over South Carolina, California, Illinois. Did I miss anybody? Missouri, Mississippi. This is amazing. Wow, I think that what this shows is, well, one, we're excited because we get to share this wonderful information and bring attention to a much needed topic, a very important topic as we talk about adolescent-based trauma and trauma care. And it's wonderful to see that there are people all across the country and the globe, it seems, that are interested in this topic. And our biggest goal today is to hopefully help you leave here today with more information on how to effectively identify and assess trauma for adolescents, but then also what can we do to intervene and provide some evidence-based treatment that will effectively help these young people. So we are so excited to have you guys here from all over the place. Thank you guys for making time. And thank you guys for making this a priority in your professional career as well. So we'll kind of jump into the topic. As you see, we go throughout this. We will use Slido a couple more times to help kind of gauge where you guys are with some of the trauma information that you have already. So what are we wanting to cover today? So there's three major areas that we will really be diving into. We could probably do a several day, conference on this topic of adolescence-based trauma. But the three main areas that we will be focusing on today is looking at defining trauma itself. What does that mean? And how do we understand that from a perspective of a developing adolescent? So we'll look at both the psychological and the behavioral components that help to define that. And from there, we will then look at some evidence-based treatment that is effective in addressing PTSD and trauma-based symptoms with adolescents, including prolonged exposure will be our biggest emphasis, which both of Alex and I have done a lot of work with. And then we're going to look at the best practice for supporting adolescents in trauma resilience and recovery. So we'll talk a lot about prevention as well as some intervention aspects that can be helpful, not only to get kids to the treatment that they need, but what are some basic kind of skills and interventions we can use as clinicians or community support people to get kids to the treatment that they need. All right, so Slido again, what would you guys say are the biggest challenges working with kids who have experienced trauma? And this may be from a perspective of personal experience in your work, or maybe even just thoughts or perspectives you have if you haven't done specific trauma-based work with children. Ooh, family dynamics is getting a lot of bursts there. Wow, I love all these responses. This is great.
And you can put in more than one answer to the word cloud if you have more than one
Yeah.
challenge. So feel free to upvote other people's answers as well.
Absolutely. I'm seeing a big theme surrounding family, whether it's family dynamics, parenting responses to trauma, trust. Absolutely is a huge component. If we don't have trust, that's going to make it challenging, right? To be able to connect with these young people who are already in a vulnerable space. Ongoing distress, lack of safety in their worlds, absolutely. Resistance to treatment, apathy. Let's see, low motivation, absolutely. That's a challenge across the board, regardless of the topic of therapy with adolescents, right? But especially when we talk about something as sensitive as trauma itself, secondary trauma, emotional awareness, accepting trauma, misdiagnosis, absolutely. I love that someone identified misdiagnosis, and that's why we will spend a good chunk of time today talking about what trauma is, diagnosing trauma, to help people get a better understanding of what we're looking for, again, to get them connected to the appropriate resources. Speaking of resources, it seems that resources themselves are a major challenge, absolutely, whether it's evidence-based treatment, whether that's being able to access trauma-based care, whether you live in a rural area, financial resources, absolutely, can be a major barrier. Acting out, avoidance, we will spend a lot of time talking about some of those things, both how it helps in the definition of trauma, but then also how that shows up in prolonged exposure and what we're going to really tackle in that trauma-based care. But I see that the biggest ones we're getting are related to family, trust, parents, unsupportive parents, shame, and avoidance. And these are all really very, very impactful components that not only prevent kids from getting the trauma care they need, but can also impact the process of therapy. So we will definitely tackle all of these. So really great answers. Alex, anything you wanted to point out that stood out to you?
No, I think you covered it really great. I think we're going to address a lot of these. And then also feel free to talk about things in the question that you feel like we didn't talk about enough. But you know what we're seeing, I agree with Caitlin. These bigger words, I think, are definitely some of the same things that we have experienced.
Awesome. Okay, so let's talk about trauma. We're going to spend some time really deep diving into the aspect of trauma, the characteristics of trauma. And the biggest component that we wanted to start with is why are we even talking about this today? Why is this such an important topic? And why do we want to make sure that people have the correct information when it comes to labeling something as trauma and then how to effectively treat and approach trauma-based care? So the biggest thing we want to really do is bring awareness and appropriate education to people on how to effectively feel confident in identifying trauma. So the biggest thing is how do we cast a wide net when it comes to the conversation of trauma, not only helping people to feel confident and not fear the topic of trauma, but feeling really confident in how to approach, connect to resources, or intervene with evidence-based care for trauma. What is our overarching goal? Again, to provide knowledge to you guys, to the students you serve, the colleagues you work with, and yourself. We all have room for education and growth when it comes to learning about trauma. There's always new information, education, and research. And that's really where we come from within Skyland Trail, and the practice that we're doing with the teams we work with is providing the most evidence-based and efficacious care to clients. So we really want to make sure that you guys are informed. And the challenge we see today, which I think is on our next slide, is where are people getting their information today? There is a huge culture on the internet, social media, about trauma, which is good and bad, right? We have people who are talking more about trauma, trying to understand trauma, but there's also a lot of really challenging, potentially harmful misinformation out there when it comes to understanding what trauma is. So we have this fun video from TikTok. And I'm going to share that real fast before we dive in. It's real quick.
I think we're having some technical difficulties and it's not playing in webinar format.
Okay, well, a little homework assignment for you guys is if you have TikTok, YouTube, whatever, type in TikTok trauma videos and you will just see a plethora of information about air quotes trauma. And this is where a lot of people, young people, older people, are getting information about what trauma is. And what is the challenge with that? So this slide here specifically looks at how trauma makes people so funny. There's this huge trend going on in the internet that, oh, I'm funny because of my trauma, which yes, we need to bring lightheartedness into therapy and into treatment. However, it can lead to a lot of exacerbation of avoidance. And it can also tend to cause a lot of other challenges with people minimizing their own struggles and not getting the help that they need. So we see a lot of things about trauma making you funny, but we also see a lot of things about trauma dumping. And that's what we'll talk a little bit about too, about why prolonged exposure and trauma-based care is so important, because we want to create a safe, contained space where people are actually working through and healing from their trauma versus masking it with humor or furthering avoidance. So a big part of the reason we're wanting to have this conversation is to bring awareness of how do we educate people and correct people when it's like using humor, et cetera, is not necessarily the most effective way to manage that.
Oh, thank you, Caitlin. Oh,
Mhm.
let's see. All right, so we're gonna use Slido again to check some facts because there are, as you know, Caitlin just mentioned, there's a lot of information about trauma out there. There's a lot of information about PTSD. A lot of it is incorrect, or a lot of it is fuzzily correct. So we want to see where you stand because this will help us kind of make a kind of more targeted approach when we're kind of going through the myths and facts about trauma. So wipe out your phones. We're about to, it be in a quiz format. So you'll get 10 seconds to fill out each question. And then we will go at the end. So You can join the quiz. We don't publish your data. You can put a fake name. You can put just your first name. But it's making a little bit of a friendly competition. All right, I see. As soon as we hit stopping growth, we'll start the quiz. But it looks like some people are still signing in. All right, looks like we're slowing down, so we'll get started. So the first question, there are definitions as to what is and isn't a trauma. All right. Um, so the correct answer is true, and we're going to get into that. So, this is something that we've seen a lot as we've interacted with patients, as we've interacted with families. And on the pro, I think there's been a lot of good reduction in stigma. There's still a long way to go in trauma. But, in some ways, people are putting it in that bucket because it's okay to have it as opposed to something that still is distressing, but doesn't necessarily meet the DSM definition of trauma. And we're going to get into why that definition is important, right? Because some people I know feel really passionately about using that label. And we're going to talk about why it is important to keep those definitions intact. Next question. No one understands what someone with PTSD is going through. This is false. So we have done a lot, since PTSD became a diagnosis in the mid 1980s, we've done a lot of good research, and a lot of good clinicians and clinical work and reports and gatherings to understand what someone with PTSD is going through. Obviously, everyone is an expert in their own experience, but we have an idea of what common reactions to trauma will look like. We have an idea of what the symptoms look like. Again, there's going to be some variation between, but there's this myth that no one can understand, and that prevents people from getting treatment. So we want to kind of dispel that so that people feel like they can be understood. All right, next, once you have PTSD, you have it for life. False is correct, right? PTSD is treatable, which is one of the really cool things that we hope to convey and hope to get out into the community. People suffer on average for 12 years or more after the trauma occurs, but we know that there are good treatments that work for most people. We know who will develop PTSD after trauma exposure. False is correct. There's been a lot of work, there's investment of millions of dollars into trying to predict, because that is the golden question. But it's really hard to predict. And when we get to baseline, most humans are resilient, which is great. So it's really hard to predict who's going to be impacted by PTSD and who's not after trauma exposure. PTSD often co-occurs with other psychiatric illnesses. This is true. Comorbidity is the rule rather than the exception at PTSD, and we'll show you some data from that. Any trauma exposure results in PTSD. Again, false. It's like most people are on that page, right? Most people are resilient. And that is great. And most people will have PTSD-like symptoms after trauma exposure. So this is true. To have a PTSD-like reaction after trauma exposure is human, right? We all get shaken up. We all might have a little bit of avoidance. We all might have a nightmare or two. And that's why we can't diagnose PTSD until 1 month after the trauma, and it's not considered chronic till afterwards. And we'll talk about this a little bit more because we need to give time for and space for people to be human before we diagnose it as an illness. Only war events count as trauma. All right, looks like we're all on the same page. This is a common myth that we see where some people say, I can't have this, they didn't go to war. So I'm glad we all are on the same page about this one. But only those in the military and in a war zone can get PTSD. Same here, same rationale. All right, so we have our leaderboard. It looks like we got a lot of people who got 9 out of 9. It looks like our hardest question, so we'll spend a little bit more time on this, is looks like the symptoms after trauma exposure. So it's great for us to know and great for us to give you the information that you need. All right, so these are the myths and facts that we just went over. And part of why we want to do this training is not only to give you the right information, but help you be a good consumer and arbiter of information. So we can't cover everything. We can't predict what you're going to be exposed to, what someone's going to tell you, what TikTok video you're going to see. So helping you approach with a level of skepticism, know what resources to look for if you are checking to see if something is true or not. Not just searching for confirmatory information, defer to trusted sources, right? Especially as we get into social media and things like that. Not everything is a trusted source, even though everyone tries to make it be perceived that they are. And it's okay not to know the answer, right? And as long as we know where to find a factual answer, that is where we can do, or where we can be helpful. And figure out who our trusted messages are. So there are different types of trusted messengers. There are experts, there are witnesses, there are those who are affected, there are those who are guides, there are those who converted, so they didn't believe something and now they do, and so on. So each of these people has a different role to play with someone who's experienced trauma, with someone who's undergoing treatment, within our own group of people who help those who've experienced trauma, and so on.
All right, so we wanted to kind of create a space to tie in all the great things we're going to be talking to by doing a case study, which we will reference throughout the presentation. The case study is going to be on client Darcy. And so through that, we'll talk about some of the challenging dynamics that Darcy experienced, but that are also very globally related to doing trauma intervention with adolescent clients. So we're going to talk a little bit about how do we understand some of the contributing factors for Darcy that led to not only trauma, but also her engagement with treatment and her outcomes with treatment. We're going to talk about some developmental considerations, not only with Darcy, but again, globally in terms of things we need to be mindful of and look out for when we're both diagnosing trauma, PTSD, and then as well as when we talk about treatment interventions. And then finally, we will talk about family dynamics as we saw in the initial Slido, or one of our initial Slidos. The family component of engaging in any type of mental health therapy we know is extremely important. When it comes to trauma work, it's even more important, I would say, and I know I'm a little biased, but it's extremely important because we need to make sure that, again, we're creating a safe space for kids to do treatment and then to go home and be in a safe space and to build resiliency in their life and in their world and with their family. So with that being said, let's talk about Darcy for a minute. All right, so just a little bit of a background on Darcy. Darcy is a 16-year-old African-American female from rural Georgia. She presented to treatment, having done some basic outpatient work, seeing a therapist. And because she was in a rural area, she also had very limited resources that she had access to. So she was doing some virtual IOP services, which again is a beautiful resource for people who live in rural areas and weren't able, for her, it was a wonderful thing for her to be able to use since she didn't have access to in-person services like that. She was a junior in high school, and when she came to treatment, she had a diagnosis of major depressive disorder, generalized anxiety disorder, PTSD. She also had a history of non-suicidal self-injury in the form of cutting, and she also experienced ongoing suicidal ideation. So that's kind of just a snapshot of her mental health history that she came to us with, which is what she presented with and what we really tackled while she was here. So when she came to us, what was she struggling with? Darcy was kind of struggling in any way you could imagine. She was a young 16-year-old woman who was developing, growing into her own self, but she was also struggling going to school. She was really struggling to make and maintain friendships, and she was socially isolated often because not only wasn't she not going to school, she wasn't engaged in any sort of extracurricular activities. There was a lot of challenges within the family dynamics. Mother struggled with her own mental health and addiction related issues. Parents were going through a divorce. She had a brother with autism. She herself dealt with a lot of guilt and shame because the abuse she experienced was from a family member. Which also then created safety and stability challenges, not only in terms of who she was around, creating an unsafe environment or what was perceived as an unsafe environment, but there was just a lack of stability within the home that created this ongoing struggle when we talk about someone who is feeling unsafe, hypervigilant, over aware of all the things in their environment. And then we also she really struggled with the fact that there wasn't access to really great resources in her area. And the family was doing a really good job, though, of trying to figure out what she needed, and we were fortunate enough to be able to support them. So within the family history, again, we're going to really dive deep into this in the presentation, but I mentioned that the parents were separated. There was a family history of substance abuse, a family history of mental health challenges. Generational trauma was also a major contributing factor, not only to the challenging family dynamics, but to both the understanding and response to the trauma that Darcy had experienced. Having a brother with autism created some challenges, again, as we talk about access to resources, the financial and kind of logistical burden on families when we talk about the needs that the whole family needed. And then one of the things that we do here at Skyland Trail, but that we encourage people to look into within your own practice, is the social determinants of health. We complete assessments for all of our patients when they come in and look at what are the contributing factors in day-to-day life that may be impacting not only their access to care, but their engagement with care as well. And what we found out about Darcy and her family was that they were struggling in a variety of areas, not only with finances to afford treatment, but also finances to cover everyday life to include rent, utilities, food, transportation. There was just an exorbitant amount of need this family had. So looking on one hand of, okay, we need to understand the presenting concerns that Darcy has with her mental health, but there's also just so much else that's going on in the background that we need to understand to help effectively treat her presenting issues, but then also provide resources to the family so that, again, we can create a sense of control, a sense of safety to the best of our ability. So again, just a snapshot of Darcy and kind of what she presented with. And what we're like I said, what we'll do is we will reference Darcy throughout our presentation to, again, kind of put a face to a name, so to speak, in a HIPAA compliant way, obviously, to help understand kind of the work that we're doing here.
Right. So we're going to talk about some of the more like epidemiology and basics of trauma here. Some of this might be obvious and already known to some of you, but we want to make sure we're on the same page. Trauma exposure is really common. Most people in the United States certainly will have experienced some sort of trauma, anywhere from a motor vehicle crash to witnessing someone pass away to being shot. And so this is common. It is different in different subgroups of the United States and other populations. So in low resource minoritized populations, trauma exposure is increased, as is combat veterans. But overall trauma exposure is really common. Here we get to that question of what is a trauma? So DSM-5 defines what a trauma is. That's exposure to actual threatened death, serious injury, or sexual violence in one of the more following ways: directly experiencing it, witnessing in person, learning that the event occurred to a close family member or friend, experiencing repeated or extreme exposure to aversive details of the event. These are all really important, and it gets into the nitty-gritty of really assessing where someone is, right? So there is some subjectivity here, but there are also some really great guidelines. So, if someone experienced something that you or I or Caitlin would say, like, yes, this is traumatic, but they're not saying, I didn't think I was going to die, I didn't think there was a result of injury, and you try to play around that and they still deny it, that's kind of what you have to go with. And we're happy to answer questions about that, because it can, there are some of these like fuzzy things, even though there are these guidelines. But this is the definition of a trauma, and what meets criterion A for DSM-5 criteria. You will hear trauma used differently when we're talking about psychological versus medical trauma. So if you hear about a trauma center or a level 1 trauma center that's attached to emergency department, that's a medical trauma. There's a lot of overlap, but it's important to distinguish. When you hear about a trauma center, like a level 1, level 2, level 3, that is blunt or penetrating injury. That is falling, that is getting shot, that is a mechanical, like motor vehicle crash or motorcycle crash. And so that's any type of event. Psychological trauma is distress resulting from a criterion A trauma. So while there's overlap in the Venn diagram, an example that often doesn't get counted as a medical trauma unless there's a blunt or penetrating injury is sexual assault. So sexual assault always counts when we're thinking about what can lead to PTSD in criterion A. Unless there's a blunt or penetrating injury, it doesn't get counted in when you're thinking about like trauma centers. So that's important to distinguish. We get a lot of questions about ACEs. So there's a lot of talk about ACEs. And then, especially in the mid 2010s, there was a big push for ACEs. Again, there's a Venn diagram of overlap, but ACEs are not trauma. So, physical abuse, sexual abuse, certainly examples that meet criterion A for trauma. Other things won't. It doesn't mean they're not distressing. It doesn't mean someone doesn't need therapy. It doesn't mean someone doesn't need medication. It just, how we think about it is backing into the symptoms and what necessitates trauma-specific treatment, because those are specific protocols and specific medications that are approved for PTSD. So PTSD, like we said, most symptoms have to be present for at least 30 days. If it's more than 3 months, then it's chronic. Once it's chronic, you need treatment for most cases in order for it to remit. And we have these symptom clusters. So we have intrusion symptoms, avoidance, negative alterations in conditions or mood, and alterations in arousal. So these are things like no one can be trusted, the world is completely dangerous. Someone, hears a car backfire and they're shaking, and they're jumping and they're checking around their locks and windows at night. They're checking around their car before they enter. They are avoiding where it happened. They're avoiding people that look like the perpetrator. They're avoiding smells at the time. It's popping into their head. They're having nightmares. There's an increased risk for physical health problems and substance abuse too when someone has PTSD. So we know there's an increased use in medical services. We know that there's an increase in pain and so on. It's the 5th most prevalent psychiatric disorder, depending on the study you're looking at, but very prevalent. And again, most people have a traumatic experience that will meet criterion A, but most people don't develop PTSD. And population-wise, it's less than 10%, but then we get these specific subgroups. So 25% in more violent traumas, women are more likely than men to develop PTSD. It is around 30% in returning OAF and OAF veterans, and in inner city, underserved, minoritized sample, it's as high as 40% that we've seen. So again, low base rate population level, different depending on the subpopulation you're looking at. These are the symptoms that we just went over. These are all required in various shapes or forms to get a PTSD diagnosis. And the PCL-5 is a great assessment tool, that self-report that goes through all these symptoms. If you're doing something that you want a clinician report, the CAPS, the clinician administered PTSD scale, is the gold standard for PTSD diagnosis, and the National Center for PTSD offers a free training in the CAPS that's you can do online. When we really think about PTSD, is characterized by avoidance. That's you're avoiding memories. Your brain is thinking, if I think about the memory, it's happening all over again and I feel unsafe. You're avoiding people, you're avoiding places, you're avoiding any sort of reminders. And if you're avoiding, you never have the opportunity to learn that they're not dangerous anymore. So your brain is constantly on alert, right? So, and we'll get into some examples of that, but the goal is to have relearning in the brain. So this is one of the first prospective studies of PTSD. It started before PTSD was called PTSD, and this is in sexual assault survivors. So we see if you look in those first 4 weeks, a majority of people would meet criteria for PTSD, but then it falls down to about half. And again, there is a higher base rate of PTSD in sexual assault survivors. The higher the 10% is not expected here, but not everyone develops PTSD, and that's something we need to keep in mind and reinforce that people are resilient. Not that it's not distressing, but the worst outcome is it can happen for everyone. And here again, we break it out by that same study of who eventually got a PTSD diagnosis and who did not. We see the people who ended up with PTSD. So the circles started high and stayed high. The people who didn't get PTSD also started relatively high and had a natural trajectory of recovery. So again, it is natural, it is human to have a response like PTSD after a trauma occurs. And that's not pathological, that is natural. But if someone does it, it's also not natural. We don't want to force anyone to have a reaction, but we also want to verify that it is. And it doesn't mean, in those first 4-ish weeks, right, it doesn't mean that someone's going to have PTSD, they need treatment right away. PTSD isn't the only outcome. So if you have experienced a trauma, you can lead to depression, you can lead to another anxiety disorder, it can lead to substance use. PTSD is just a common one and one that's often talked about. And again, it's often comorbid. And here's where we look at that in the National Comorbidities Survey, and you can see most people have 3 or more diagnoses. And when you're looking at men and women, a sizable chunk do. So comorbidity, again, is the rule rather than the exception of PTSD. Which leads to something we hear a lot, which is I have to treat insert something else, the substance abuse, the depression, the social phobia before I can get them ready for PTSD treatment. And there's been a lot of research into this, and the answer is you don't have to. So obviously, if they are in need of acute medical detox, if they are an acute risk to themselves or other people, you have to address that first. But there, Agnes van Minnen in the Netherlands has done great work showing that you can do it while someone is actively psychotic. Sudie Back and Kathleen Brady at MUSC have done a lot of work showing you can treat the substance abuse and the PTSD at the same time, because often they're using substances to cope with the PTSD, right? So you're just going to end up in a negative feedback loop if you don't. So the idea that someone has to be ready for PTSD is a big myth that we hope that you walk away from, or for PTSD treatment, that you walk away from knowing that in most cases is not the case. If you're in doubt, and we talk about this a lot in our own clinical team, back into the symptoms. So when you think about evidence-based treatments for PTSD, which we're going to talk about, most are exposure-based, and then there's cognitive processing therapy, which is more cognitively based. Would you have a target to treat, right? Would you have something to do exposures with? Would you have something to do imaginal exposures with? Would you have something to do in vivo exposures with? And if not, it doesn't mean it doesn't need treatment. It probably just means that it might not be PTSD and it needs a different treatment, maybe more general CBT, maybe more general DBT, or something specific like a GAD protocol. But that's something we're always going to go back to. What's the target here? Where will we target treatment?
Awesome. Thank you, Alex. So that was a really great overarching kind of view of trauma and PTSD. And I saw some questions popping up, which we'll get to, but we want to be able to acknowledge really in depth here, like a deeper dive of trauma in children and teens. So we know all the information about what trauma is, what PTSD is, and how do we start to pick up on that when it comes to identifying that in children and teens? It's always going to come down to a thorough assessment, a thorough background of the client, regardless of age. But what I wanted to start with was kind of giving an overview of what are some of those red flags, some of those warning signs that maybe there is some trauma that's happened or going on with a child. So I broke it down into the three kind of developmental stages to give an idea of what trauma may present as within these different developmental stages. Again, this is not set in stone. This is not, the only things that will happen, but just to kind of give an idea of what are we looking for when we talk about some of the presenting symptoms that different age children might experience. So looking at the preschool age children, 1 to 5, things like temper tantrums, irritability, and sadness. Is this something that maybe is new or getting worse? Some of the regressive behaviors, things like sucking their thumb when maybe that's a behavior that they had stopped doing, or maybe they're looking for their pacifier when that's something that they had gotten rid of before. Maybe it's something that they are having some bedwetting in the evening when maybe that was something that they have been working on for years and really hasn't been an issue. Physical symptoms such as stomach aches. Do we have a kid who's continuously saying that they're having stomach aches, which again, as we talk about comorbidity, those are things that can show up in things like anxiety as well. So again, this is where effective, thorough assessment is going to be your best friend. Moving into school age children, ages 5 to 12. Again, it can be a lot of similar things when we talk about some of that irritability, the hyperarousal. We look at increased negative thoughts about self and experiences since the trauma. Again, with older children, you're going to have a little bit more of a self-awareness and a self-identity. So how has that trauma impacted how they're seeing themselves, how they're engaging with the world, which then is going to impact their experience, right, with themselves and with their environment. So we also look at things, again, feelings of irritability, being withdrawn, numb, increased feelings of hopelessness, and possibly reenacting out the trauma in play. Again, not something that happens every single time, but is this something where you're seeing a child who is engaging with their dolls and maybe they're doing a lot of fighting and violence versus before it was just kind of like silly fun play. We've mentioned the physical symptoms as well. And then we're kind of getting into the older group with teens ages 12 to 18, which is primarily the population that we do see here in our program. And this age group is going to be the most similar to what adult trauma presentation is going to look like. So again, it could be things like regressive behaviors, et cetera, but a lot of it is going to be the impulsive, risky, self-destructive behaviors. A lot of what we see this show up as with our clients are things like self-harm, even the chronic suicidality or hospitalization that is resulting of intense or ongoing self-harm, trouble expressing emotional experiences to others. Again, through our Slido, trust was one of the biggest challenges that came up of how to engage in effective treatment with adolescents who have experienced trauma, and trust itself is something that can be really hard. So how is a developing teenager who has massive trust issues going to struggle, right, with everyday life, whether that's going to school, whether that's being at home and feeling they're in a safe environment, learning to rely on other people and building kind of those collaborative relationships, decreased self-worth, out of place sexual behaviors. This is something, again, our team explores a lot when we talk about developmentally appropriate sexual behaviors, experimenting, exploring, versus something that is maybe falling more into the risky or unsafe behaviors, self-harm and substance use. So again, just kind of a snapshot of what trauma may present itself in with children and teens. And that's not just limited to these things, but kind of just to give you an idea. So again, the importance of assessment, how are we taking these things that we know and then using that as a kind of a guide for further assessment. Risk factors, always a good thing for us to talk about, right? When we're understanding any component of a mental health presentation, severity of the event is always something that's going to be important for us to take into consideration. Again, is it something that happened specifically to an individual? Was I in the car accident, or did I see my parents get into the car accident, right? Not to say that either of those is more or less stressful, but again, it's going to impact how the individual experienced and how they are affected by that long term. When we talk about things like that, was the police involved? Were there, something, we get a lot of situations where maybe there's domestic violence and kids were separated from their parents. Was there some sort of abuse that happened where they had to be removed from the home and go live with another family member, or death of a loved one as well? So when we talk about some of those contributing factors, that's going to go back to increasing the likelihood that someone may develop PTSD versus just I've experienced trauma. Proximity to the event, again, as we talk about about whether they've experienced the event themselves versus watching someone else do experience that. This has been a really interesting conversation with more and more media exposure, TV exposure, social media exposure, and how that can be impactful for young people, again, as they're learning about the sense of safety and connectedness to their family and to their world. Caregivers' reaction, this is something that goes back to what we've taught, what I've really been emphasizing in, this first, I guess, hour or so, of the importance of family involvement when it is when trauma is identified, diagnosed, and treated for adolescents. So when we have a young person who is taking the risk, they build up the courage and the bravery to tell someone about the trauma that they've experienced, no matter what that trauma is. The way that a parent, a guardian responds can have an impact on the development of PTSD. So looking at the aspect of a more supportive parent or guardian versus someone who maybe doesn't have their own understanding or doesn't really know what to do with that, and how that can then impact the way someone maybe internalizes or learns to avoid the feelings and experiences they're having, which we know contributes to the development of PTSD. A prior history of trauma is also going to potentially impact someone's development of PTSD in traumatic situations. And again, we are seeing kids who just have more and more trauma, who are experiencing numerous different types of trauma, and the way that that can exacerbate it. So a lot of times people will refer to that as complex trauma. But again, we want to talk about effective assessment and looking at trauma experience versus a diagnosis of PTSD and how that's impacting them developmentally. And then family and community factors. I mentioned with Darcy, generational trauma. Again, when we look at the way people are responding, the way that families may be normalizing experiences because it's happened from one generation to the next. This can be related to substance use addiction. This can be related to sexual abuse that may have happened to parents and now it's happening to children, neglect and abuse. And this is where we as providers, we as people, as humans, we can understand people's life experiences and create some level of support and intervention for not only just one individual like Darcy, but also maybe for her family. And that was something that we also had to tackle, was how do we help support this family when so much has been going on for literally generations? We also talk about things like racism and discrimination that can impact a child or teen's experience with developing PTSD symptom expression. So those are some of the risk factors when we talk about PTSD development. And then what are the potential impacts when we talk about experiencing early life trauma? Alex talked really in depth about the ACEs and how the ACEs has been a great study, great information that we've learned about the long-term impact of those adverse childhood experiences. When we talk about trauma and PTSD itself, how does that impact a young person who is learning again to develop a sense of self, developing relationships, building goals for their future? So a lot of the things that we see be impacted for young people when it comes to trauma and PTSD is the impact it has on their social life and their interpersonal challenges. If I've experienced trauma as a young person and I have those trust issues that everyone mentioned in our Slido, it's going to be really hard for me to open up and talk about my feelings. It's going to be really hard for me to trust other people that I can be safe with them. Because if someone in my immediate environment, in my immediate circle has made me feel unsafe, who can I actually trust? Then how does that branch out not only to creating friendships, developing romantic relationships, or creating a false sense of what a healthy relationship looks like, may leading to things like risky sexual or just general behaviors in general. Greater risk of comorbidity when we talk about mental health diagnoses, as Alex mentioned, that is the rule, not the exception when it comes to PTSD and trauma. We see that people have young people having more diagnoses, ADHD, depression, anxiety. It could be developing an eating disorder, substance use disorder. So again, creating a greater risk for learning maladaptive coping strategies to the trauma that they've experienced and are now learning to avoid throughout their life. Physical health implications. Again, we mentioned that stress, anxiety, that can show up as stomach aches, headaches, body tension. How is that going to lead to long-term health challenges? School performance. If I don't feel safe at home, if I don't feel safe in myself with adults, how am I going to be able to show up every day at school and put my best foot forward, right? It makes sense. But also maybe I'm not sleeping, or maybe I want to sleep all the time and I'm not getting my homework done. So school performance is a big component of what we work on with adolescents, especially within the prolonged exposure modality, to build in resilience and attack that avoidance that can show up so often when it comes to school. Some other things I've already mentioned: pain, potential perpetration of trauma to others. Again, something that can be a challenging topic when we talk about understanding trauma within minors and adolescents. However, how are we helping them to understand what they've experienced, understanding the norm, and then also the aspect of being open and not avoiding what they've experienced. Greater risk for more trauma, again, as we talk about engaging in risky behaviors, as we talk about not protecting their sense of self and creating an aspect of where life matters and their safety matters. So that could potentially open up doors to be involved in other traumatic events. Exposure to the criminal justice system, which we know can create a kind of domino effect of lifelong challenges. And then just an increased need for healthcare resources, right? And so when we bring in things like social determinants of health, not only do they have the resources to then rely on the system of healthcare for those resources, and now we're opening up more cans of worms. So a lot of different components that can really impact the lives of young people, and a good snapshot of why this work is so important, why a conversation like this is so important, so that we can get a better understanding of how to intervene at an earlier stage for these young people. Some of the common reactions to trauma. So this is something that we do within the prolonged exposure therapy protocol. We explore specifically, like this will be in our first session, we'll talk about common reactions to trauma. And why do we do that? Why do we want to lay out there all the terrible things that could happen when someone experiences trauma? And that's to create a sense of norm. That's to create a space of safety, so that a young person who maybe doesn't understand why they're so angry and they are cutting themselves, or maybe they are starting to use substances because they don't want to feel scared and alone and angry all the time. We want to create a sense of connectedness that young people can utilize to better understand what they are experiencing. So we look at things like emotional reactions, cognitive reactions, physical reactions, and interpersonal reactions. Obviously, I'm not going to go into all of those different areas, but we will unpack all of those things, because not only does that help to create a sense of norm and help build that trust we're talking about for more openness, but it's also going to kind of be light bulb moments for some of these kids. I love having a PE session with a kid and I'm like, did you know that, this emotional numbness is a natural response to experiencing trauma? And it was like, oh no, well, I just thought that I was broken. I thought something was wrong with me. And so these are just really great ways to create conversation and to help them learn about themselves. And again, build that buy-in and that motivation to engaging in trauma-based therapy. So some specific examples on the next slide that we talk about a lot in our work of trauma-based care for adolescents. What does that look like? What are these common responses to trauma that we are going to see every day? It's not always just going to be sleeping all day, right? It may not just be a refusal to go on elevators or be in a car, but it could be things like missing the bus or on school days. Is this a learned behavior that I don't feel safe when I go to school? So I'm doing all these little things that lead up to me missing the bus every day and maybe not going to school, falling asleep in class, being easily startled or jumping when asked a question or tapped on the shoulder. New behaviors of self-harm, again, have young people develop such a sense of hopelessness, lack of sense of self and safety, that they're now turning to other behaviors to maybe generate a feeling or feeling control in some way. Coming to school smelling of drugs or alcohol, maybe even openly using drugs or alcohol. Maybe there's just a total lack of concern. We're not trying to even hide it, but maybe it's a matter of using substances as the way that I've been able to escape from the memories and the symptoms I'm having every day because I had this experience of trauma. Increased crying spells or anger outbursts. Again, poor hygiene. These might be some things that are very normal responses of an adolescent teenager, right? kids need deodorant, kids need to take showers, and they may not have the best hygiene routine built up, right? They may be a little bit emotional and they may get angry and they may yell. So it's a matter of understanding, are these new developed behaviors since something has happened? Is this out of the norm for this young person? And how is it becoming dysfunctional in their daily life? Things like wearing extremely large clothing. This is something that has shown up a lot when we look at sexual abuse. Victims who don't feel safe wearing clothes that are too small, they really just want to hide, they really want to just pull away from others, and that makes them feel safe, right? That would what would be called a safety behavior. Wearing a mask, keeping the hair over their face or eyes, literally wanting to disconnect themselves, not be seen by others because they just cannot deal with how they're feeling or the way that they don't want to engage with people that much. Changes in eating pattern, as well as performance in school, which has already been addressed as well. So there's a million and one different things, but this is just, again, a snapshot of how that trauma can present itself when we talk about adolescents specifically, and kind of how trauma can show up and impact their daily life.
All right, so now let's talk about some treatment. So again, thinking broad themes, what we want you to leave here. PTSD is treatable. People suffer on average 12 years or more. To Caitlin's point about common reactions, a lot of times they're just like, I just thought this was my life. So it's treatable. We want to instill hope. And there are treatments that work for most people. The problem is most people don't get them. The majority of people who have PTSD who do go to treatment don't get an evidence-based treatment. Dropout is huge. Again, this goes back to the idea that PTSD is a disorder of avoidance. Settings like ours, or like some of the programs that have popped up for veterans in and outside of the VA where they're intensive are really great because it helps mitigate that avoidance. But anything we can do to help people not avoid. I even tell people when when I have adults, right, that I'm treating, you're not going to want to come next time. Let's talk about why you want to come. So really getting ahead of that avoidance. There are a lot of treatment myths about trauma. Thinking about the trauma as bad is when we hear a lot, and it's going to re-traumatize them when we do an imaginal or in vivo exposure. And the fact is that it's not. That's how our brain relearns that things are safe, and that facilitates avoidance when we think that, when we tell people that you don't need to be thinking about this or talking about this. And we already talked about the idea that people have to be ready, again, unless there's a severe medical or safety contraindication. There's been plenty of data to suggest that you can jump straight in. Again, we see this idea that you need to do therapy before starting trauma-focused work. And the answer is research has shown that you don't. And a lot of times that facilitates avoidance, right? Okay, let's talk about this when you're not even addressing the underlying issue, which is probably the PTSD. Uptick in symptoms with treatment means it's making it worse. PTSD treatment is full with analogies. Everyone makes their own. One of the ones that I like to use with patients is we're going up into a dusty attic and we're unpacking some boxes. When you brush off the dust, you might start sneezing. You might get a little stuffy. It doesn't mean you're getting sick. So, talking about being realistic about what might or might not happen. And sure, for some, there is a little bit of an uptick, but then you come back out if you stick with it. And for some, you don't have it at all. So we also don't want to scare patients to say, you're going to have an uptick in symptoms. We don't know who that's going to happen for, but we want to let them know that it's normal if it does, and we're here to support them. There's also this myth that if you have multiple trauma exposures, multiple different kinds, chronic, it doesn't work. We know that it works. There's been a plethora of data showing that even if you choose one target trauma, often it broadens its impact to all the other traumas that might be leading to PTSD symptoms. If not, you just pick up and with the next one. When we're talking about efficacious treatments, the main first-line treatments are cognitive processing therapy, or CPT, prolonged exposure therapy, or PE, and trauma-focused cognitive behavior therapy, TFCBT, is for kids. Pharmacotherapies, so paroxetine and sertraline, so Zoloft and Paxil are FDA approved. There is a lot of evidence also for venlafaxine, and then potentially evidence for brexpiprazole. But those haven't gone through FDA approval yet, especially on the brexpiprazole side. The treatments, while on average are really effective, they don't work for about 33% of people when we looked at meta-analyses. That could be for a host of reasons. It could be that they don't work. It could be that there's social determinants of health preventing effective treatments. So it's hard to make progress in therapy if you're worried about getting food on the table. So how do we hook them up to resources while we're putting them through treatment? And again, that's not a reason to not treat people. We just want to make sure we're helping people get the most out of treatment that they can. So let's think about PTSD and PTSD treatment in a translational manner. This helps me think about it. It helps some patients think about it. Other patients, it's not. But this is where we can think about the mechanism of what's going on when we're treating PTSD. So one of the really, we're thinking about kind of cool in a nerdy way, obviously not cool in a humanity way. But one of the cool things about PTSD is we have this target event. We know you can have every known and unknown risk factor, and you're not going to get PTSD unless you have a criterion A trauma. And so we have this kind of a marker that we can think about. And PTSD is considered a fear-based disorder. So this is a state of arousal to an aversive stimulus with explicit perceived threat. So the memory, the street where you got in the crash, someone who looks like someone who assaulted you. So we know the cues. So we conceptualize PTSD in part of a failure of fear extinction. So we think back to that curve where everyone starts out and then the people who don't develop drop down. We can think of that as fear extinction. And so when we talk about that, we can think about that as, if you remember Pavlov's dogs, right? You rang the bell over and over again, and eventually the bell became associated with food, even though the bell wasn't food and the bell led to salivation. That's like traumatization. We'll get some examples. And then, so that is fear conditioning, trauma exposure. And then fear extinction is where we unlearn that, right? Or actually, we have new learning. So we never erase it. We never say that it didn't happen. We're showing our brain that it's no longer associated. And this allows us to study it really well. So when we when we talk about evidence-based treatments, broadly, we're thinking of cognitive behavior therapies, right? And there are a bunch of different cognitive behavior therapies. It's both an overarching with our theoretical orientation. Then you have specific protocols, and you also have what we have called second wave CBTs like DBT, ACT, etc. Cognitive behavior therapy is evidence-based, and it focuses on thoughts, behaviors, and emotions, and that's exactly what evidence-based psychotherapy for PTSD focuses on as well. Here's where we get back to Pavlov's dogs, our little joke, but that's a good way to conceptualize it as we think about it. So when we do this in mice or rodents, or rats, so all rodents. So fear is interesting because it's preserved across the mammalian species. So it looks a little bit different in everyone. We have fight or flight, for instance, rodents freeze, but we can test this and we can learn a lot about how to maximize our PTSD treatments and understand PTSD. So we have this light here, and if the light is objectively safe, right? No, the rodent's like, all right, it's a light. But if we pair the light over and over again with a foot shock, the rodent will then learn that, oh, wait, this light on means I'm about to get hurt, right? The light is dangerous, when previously it wasn't. And we can combine it with a startle cue to see how much you startle more. So we startle more at night, rodents startle more in daytime because they're nocturnal. But we can get an idea of what fear potentiated startle looks like. And this is a great model for trauma exposure, right? We're pairing something previously neutral and now it's becoming dangerous. And our brain's like, this thing that is objectively safe, right, is actually not safe. So that is kind of like the criterion A trauma. And that is where we get onto it and map onto it and we can use it to study it. So CBT is learning, right? So fear conditioning overall is learning. CBT is learning. So you're shaping, you're reinforcing, you're modeling, you have reward, you're doing inhibition, you're trying to habituate, right? So all the things you do in your practice outside of PTSD are also learning mechanisms that we're just applying them here specifically to PTSD. So again, here we have our model of the rodent. This time we're using a sound instead of a light. We're pairing a sound, foot shock, and it's freezing, which is their danger cue when it hears the sound because it's learned that the sound is danger. If we think about this, so this is, if we have any, I don't think we had anyone from Ohio, but this is Dead Man's Curve in Cleveland. And previously neutral, right? It's a little hairy, but you're going to go through it. If you get in a car crash in Dead Man's Curve, that's like the foot shock. And then that would be, when you go through Dead Man's Curve again, if you've paired that and you have PTSD, your heart rate's going to be racing. You might avoid doing it, right? And that is that experience. So then we get into PE, right, which is the therapy that we're going to focus most on. And prolonged exposure therapy is an evidence-based therapy for PTSD. It's been studied since the 1980s. It's endorsed by all of the evidence-based guidelines worldwide and by the ISTSS and IOM. It's a manualized protocol. It has workbooks for the therapists and patients, so it's accessible. It's been shown to be effective in adolescents as well as adults. And there are really great training programs. So we've done one through Emory University where you do a training and then you have 6 months of consultation where a consultant listens to your tapes, makes sure you're fidelitous to the model, and that you're meeting 80% fidelity for each of your sessions. It helps gives feedback to really kind of get into the pattern of practicing really well. And this is what the manuals look like. And there is an adolescent manual that Caitlin can talk more about.
Yeah, so it's really awesome that we have a manualized curriculum like PE to work with because it creates structure, it creates consistency, right? As we talk about fidelity and being an evidence-based treatment. What's even better though with PE, and the reason we love it so much too, is that there is a whole manual built for adolescents. And this creates a space for the kids to have their own workbooks, their own resources right at their hands, but it's also just more developmentally appropriate. It has examples and metaphors that are a lot more relatable that they can understand. And it's easy to use. We can track their progress and we can help them to build insight in this space. So this is a great tool for anyone who is looking to learn more about PE itself. Both manuals are fantastic. But you'll see if you start doing PE with adults and then you do PE with adolescents, there's going to be some differences. Not to say that it's not translatable, but it's a matter of just being able to find those developmentally appropriate metaphors and examples to help the kids connect with the treatment. So what does PE look like as a therapist? What are my sessions going to look like and how am I going to use this tool with my clients? So typically there's 10 to 15 sessions that are going to be 90 minutes each. Each session has 90 minutes. It feels like a long time, but man, does it fly by. These kids will absolutely say, hey, are we done yet? But we're going to stick with it. And then they're often surprised that 90 minutes went by so quickly. So again, we're using that CBT framework to really grade exposures to these feared stimulus. A lot of times it can be things like conversations with certain people, sitting in certain places in the classroom, not going to the classroom. Is it a matter of specific things like coats, cars, people, men, older men? So things that we're looking at that these young people have developed a fear of that are objectively safe, and we can help relearn what is safe. So what we're doing throughout these 10 to 15 sessions is we are confronting trauma cues that lead to discrimination. So we're looking at things like memories. Are these specific memories related to the trauma or similar feelings or experiences that they are then avoiding? Reminders and situations. So again, we talk about being an adolescent, learning about life and seeing maybe someone who's developed who's experienced trauma, they're going to then experience the world in a different way. So we want to be able to confront the trauma cues that have led to challenges in other areas and help them to kind of piece together those experiences. So one of the things we're also going to be doing is extinction learning using exposure to fear cues in order to reduce the fear. So again, we will be doing things like imaginal recordings where they're actually going to talk through their trauma memory that has been identified, and they have to listen to that back in between sessions. And then we also do what's called an in vivo exposure, where we will plan different experiences for them to face those feared situations, memories, and reminders that have led to the prolonged distress that their PTSD is causing. So every session is going to include a level of exposure as well as processing and exploring what they're learning, what they're more insight is being developed based on their understanding of what their trauma has done to impact their life.
And so, When we think about PE, that's analog to fear extinction. So you're repeatedly gradually confronting memories, reminders, and situations, like Caitlin said, that have been associated with the trauma. And the goal here is not to unlearn; it's to show your brain that they're no longer dangerous. So a classic example, not related to teens, but it can help us take us out if we're trying to anchor ourselves, is with veterans who were in Afghanistan or Iraq, right? There were objective threats of roadside bombs in those areas. And then trash day is really scary in the United States, right? Because there are things that you've been trained to scan for things on the side. So how do we do exposures to show your brain that in this context, right, in most cases, something on the side of the road isn't going to be dangerous like it was. And we're doing graded exposure. So we're not throwing someone into the deep end. We're starting with something feasible. Again, because if we started and threw you into the deep end, your brain is like, this is still dangerous, right? This is freaking me out. Look, that was terrible. And so we want to also build mastery, right? You can do something that's a little bit anxiety provoking and show your brain, A, it's not dangerous, but also you can do it. And so we are going to, as I change to share sound, we're going to hear from a therapist, hopefully, if our tech is working, because this can be really scary for a lot of therapists when they're starting out.
Doing prolonged exposure PE therapy with Darcy was definitely simultaneously one of the hardest and best things that I've done as a therapist. She was an incredible client to work with who had a lot of factors stacked up against her, a lot of intergenerational trauma, as well as family trauma that had specifically impacted her and was the memory we were working on. It was so difficult hearing her walk through her memory for the first time when we did an imaginal. I think I may have been in almost as much distress as she was. And I definitely had a lot of doubts in the beginning of doing PE with her. It was a really hard process. However, over our sessions, I was able to see so much growth and change in her. A lot of what we focused on was her owning that this thing that had happened and kind of the outcomes of reporting this thing within her family were not her fault. She had held on to a lot of blame and a lot of really just blaming herself for how it had impacted family for her to report some things. And by the end of us working together, she was able to say that these things were not her fault and that she is not responsible for other people's reactions, and she needs to look out for herself, advocate for herself in a world that will not advocate for her a lot of the time, in a world that will try to push her down, that she is able to take the reins. And that was an incredible thing for me to witness, and to see that PE actually does work. I think it's, you train and you learn about it and you see it on paper, and it's so much different when you get into it and you start actually doing it with a client and you see this huge shift in them. I will say I had so many doubts in the beginning about, is this actually going to work? Am I just punishing her, making her walk through these difficult memories with me every week? Making her do these in vivos, facing these things that she's avoided, and seeing her distress was difficult. And you see why those things work. I saw her take on so much more confidence and self-assurance that she is able to do these things that she has avoided and have felt so difficult for her. She is able to face this memory and know that it cannot hurt her anymore. And I was so proud of her throughout this process. And I'll say also proud of myself, because I sat in a lot of discomfort till the end and was able to see why this discomfort is meaningful.
So, we always like having those stories because it does seem scary, right? And there's a lot of data showing that therapists, when they're first doing exposure, it is something that you're like, oh my God, what am I doing? But it is helpful, and it is helpful to see the change that it induces. So we're talking about exposure in kids and teens specifically. There's TFCBT and PE, and people are like, what's the difference? Why would I do one or the other? They are both excellent evidence-based cognitive behavior treatments for PTSD. Both involve exposure, just very differently. When we talk about why PE works in our setting, it's a session-by-session protocol, whereas if you're familiar with TFCBT, it's the practice mnemonic. It's a set number of sessions, it's a timeline, which works really well for our setting. And TFCBT is designed for caregiver involvement. So we have a residential and PHP program. Kids are often not living with their parents or only for part of it. And sometimes parents are the problem or the perpetrator. And so it makes that hard. Our population is 14 plus. So that's, teens are where PE starts to be validated. For young kids, not so much. You would do TFCBT. And they're getting many of the other skills, like in the first prac part of TFCBT and the CBT and DBT program that they're already in while they're here. When we wouldn't do PE with someone who's in our setting, we would refer to TFCBT if they're maturity considerations. If psych testing comes back and says there are milestone or developmental delays, so they're not, they are a teenager in age but not in development, or if that's the patient's preference and it's not avoidance. If it's avoidance, we will tackle that. And this is the practice mnemonic of TFCBT. If you're not familiar, so you see there are a lot of skills involved. There's a lot of parenting skills. But you are building a narrative, you are processing, you're doing in vivos very similarly, just you're going through it in a more tailored manner to each patient. So the goal is to get through practice, not necessarily a number of sessions.
So we've been talking about PE and the two main components of exposure that are utilized, the first being imaginal exposure listening sessions. So within those 10 to 15 sessions, we are spending part of that time conducting the imaginal exposure, where the young person is talking through the identified trauma memory in detail. Again, it is a gradual exposure where they're going to talk more and more in detail about it, more and more about the experience, the details, the sounds, the smells, all of the things. And so one of the things we have to do, we are a residential space that does prolonged exposure, which makes it just a little more interesting for how these kids carry out their listening sessions. So what the homework assignment is we have a session on Monday. You're going to listen to that session a varying number of times between now and our next session, right? So you want to make sure that if you're going to engage in prolonged exposure, you're creating a space and a system that is going to effectively engage those kids in these listening sessions, again, which is a form of that exposure. We want to confront any and all avoidance. We see a lot of kids who fall asleep during their imaginals. Oh, I have to go to the bathroom 5 times during my imaginal listening session. And so we're going to talk with them about how that shows up as avoidance. Are you not wanting to listen to this? Oh, well, it's just boring. Okay, well, why is it boring? And then you can tie that back to the avoidance, the emotions that they're not wanting to experience, the feelings that are coming up when they're listening to this, identifying safety behaviors. We have kids who carry around fidgets all day, every day, and one in every pocket, and they want to make sure they have their fidget during their listening session. We are sadly going to tell them, sorry, buddy, you can't have your fidget, because that can be a safety behavior. They're wanting to have some sort of distraction, something to self-soothe during that imaginal listening session. And what we're wanting them to do is to show them, build that confidence that, hey, I can feel fear, I can feel sadness, I can feel hurt, and I don't have to avoid that. I can sit with that and I can deal with that discomfort, which again, we're breaking that cycle of avoidance that has been going on for so long. Things like medication usage, writing, staring off, sleeping, all kinds of different things, and we'll get creative. We had one young person who said they kept falling asleep because they were tired. So they would do some jumping jacks in between, before their session, during their session, and after the listening session. So again, we just have to identify those safety behaviors and get creative. And with that, we involve the client. How do you make sure that it's something that not only they're willing to do, but they're open to do? I'm down to do, look crazy and silly sometimes, but is my 16-year-old client who's too cool for school going to be willing to do some of these little silly things in the middle of the milieu? Maybe not, how do we make sure that it's things that they're willing to do? Because the more likely that they're willing to do it, the more they're going to engage and the more efficacious the treatment's going to be. Utilizing your team as effectively as possible. Again, making sure that people know kind of the basis of what's going on and how they can be a part of the solution and not the problem when it comes to creating interferences that may be not even intentional. And then next up is the in vivo exposure development. This is something that can be a really great way to not only build rapport, but also like trust with your client. The in vivo exposure, it's really funny. Every client I've had when I'm doing in vivos with them, I'll say, you know, how school, for example, like, so I know that you're not going to school. How is that impacting you? And so we'll talk about that. And then they'll maybe give an example of like, oh, well, I didn't like being in the parking lot of my school. And then they'll be like, oh crap, you're going to make me go to the parking lot of my school, right? So they learn that like they start to learn where those areas of avoidance are coming up and how that can be an opportunity to expose themselves to the discomfort that that experience was leading them to. So you can do in vivo exposures in all different types of settings, inpatient, outpatient, with the family, with peers, with other staff, with other adults. Get creative. Appeal to different senses. This is again an opportunity to get creative. Alex uses a really great example of a client who had a fear of oranges because the smell of oranges was associated with their trauma. How do we bring the olfactory sense into the aspect of managing avoidance as a component of getting creative and exposing someone to something they've been avoiding for so long? Using technology, a lot of things we do here in residential treatment when it comes to, again, in vivo exposure is using technology as our friend. That could be using videos, that could be using sounds, that could be exploring websites, you know, things like movies, shows, even like sex education videos, substance use videos, etc. You might have parents who have specific items of clothing or memorabilia that are specifically related to a trauma that you can bring in to have a client sit with and understand and explore the discomfort that that causes. Providing incentives. We do a lot of incentive-based programming here. Again, as we talk about learning, if there's a positive experience, they were going to be more likely to engage in it. Excuse me. Don't be afraid of feelings. So again, working with teens can be challenging in a number of ways. They have big feelings. They may not want to express any of their feelings. They may want to wait you out and you have to wait right there along with them. So part of this work is also kind of being mindful of your own experience and that we don't want to become a colluder of avoidance. We don't want to encourage them to avoid those feelings because we may feel uncomfortable. A good example of this is I've had a client who has started to throw up during their imaginal exposure in a session. And, you know, my human nature wanted to be like, oh my gosh, we need to stop because this is not good. But what would I be teaching this person if I said, yeah, you're uncomfortable and you're distressed? You can't handle that, so I'm going to take you out of the situation. We would be reinforcing those feelings of discomfort, fear, all of that. So we need to deal with our own things, be mindful again of objective safety and making sure that we are dealing with uncomfortable feelings and using that in processing. Knowing your client is always going to be important and reassuring clients of safety, making sure that they feel safe in every situation, that they're willing to engage in any exposure. And again, we're never going to put a kid in an unsafe situation, a client in an unsafe situation, but we're going to figure out ways to help them explore the feelings that they're avoiding so much. You know, especially when we talk about things like sexual abuse, physical abuse, an assault, we're never going to engage in anything that's going to be unsafe to an individual. We're looking at ways to help them identify avoidance in everyday life that are then connected back to that trauma. Things that we've done to, again, get creative, bringing in law enforcement when we talk about family violence, when we talk about maybe having been arrested, utilizing video, movies, music, using old clothing, writing letters to family, doing letting go ceremonies, engaging things like food, bringing in perfumes or soaps, going to crowded places, riding in cars of certain types with certain people, sitting in the front of class, observing fights and arguments. The list goes on. And it's a way to, again, we're creating a safe space for these young people to deal with and expose themselves to the feelings that they've been avoiding for so long, and then tie that into their everyday life and how they can build more resilience and strength and control over what they've been avoiding for so long. So that's imaginal versus in vivo exposures, and that's a huge component. Things we want to think about when we're doing PE with adolescents: confronting avoidance. If I had $1 for every time I said avoidance, I would be living in Bali at this point, because avoidance is the biggest component of what we're trying to address in PE, but create so much learning about the dangers of avoidance within their life. You want to meet the client where they are. You know, we don't want to set them up for failure by, again, diving into the deep end by starting with an exposure that's way too hard that maybe they're not ready for. What are they willing to do? Do we need to make some accommodations to the treatment modality with an efficacious manner that will encourage them to be more motivated and engaged? When you're a part of a team, I mentioned this, you know, but making sure you can utilize your team. How is everyone educated on the basics of the modality that you're using? Because we get things like, what are you guys doing with these clients? You know, they were worse before this, they were worse now that they started PE than before. And that's where that education comes in. And even a conversation like this is so powerful because, yeah, this kid who has been avoiding their feelings of fear and anxiety and going to school and all the things, now that they're talking about it and they're facing it, it's going to be uncomfortable. And we're going to see them express things in different ways. And we want to encourage that, not discourage that, while keeping them safe. I mentioned modifications during listening sessions, and do not collude with avoidance. We don't want to be a part of the process where kids are avoiding things, right? It's uncomfortable sometimes. PE is hard work. I will not pretend. There have been times I've sat in session and you just want to give these kids a hug, or you just want to say, you know, like, let's just stop. But that's not going to help because we need to make sure that they feel safe and that they learn that they can manage these difficult feelings. And then getting parent buy-in, which I'll talk about a little bit more on one of the upcoming slides. We also want to talk about medication management. Medication management is not something to fear when we talk about engaging in prolonged exposure treatment. It's important to take that into consideration when you are engaging in prolonged exposure therapy. Are there, you know, we have kids who are taking medications to manage their nightmares, et cetera. How do we tie that into the conversation of what they're accomplishing here, how they're reaching their goals, not only with therapy, but with medication management? And then, as I mentioned, medication changes are not an indicator to stop PE or to prevent the starting of PE. And then this is just another perk of working on an interdisciplinary team. We're very fortunate here to work very closely with our psychiatrists, and we're able to share experiences about what this client is reporting based on their symptoms, both in therapy and within the medication changes that are happening. We also want to talk about things like substance use. Again, it should not be used as a barrier to starting treatment or continuing treatment. We want to make sure assessment is happening. We want to make sure that we're not only looking at motivation, but also safety. Is this an aspect where maybe a detox or some sort of medical intervention is needed to make sure that this person is physically safe to do the prolonged exposure? But that's not to mean that someone who is using substances or has used substances is not a good candidate. Because as Alex mentioned early on in this presentation, substance use 100% could be an aspect of coping or an aspect of avoidance to deal with the trauma that they've experienced. Comorbidity, again, as Alex mentioned, is the rule of PTSD. There's going to be a lot of things that are going on. And a lot of times what we hear is, oh, I'm not ready to do PTSD. Do my PE work. I'm not ready to do trauma work yet because I need to tackle my depression first, or, oh, I need to work on my family issues first. That's fair. No one is ever going to be ready to confront the hardest, most challenging, most uncomfortable things in their life. And that's okay. And that's where strong therapeutic rapport and having evidence-based modalities and great relationships with your clients is going to help them get this understanding education to do therapy like this. So again, we want to be able to tackle one thing at tackle the PTSD and finding ways to attack the other things as well, because some of this is generalizable to some of their other symptoms that they may be experiencing. And maybe they need alternative treatment interventions as well. For example, is here in our program, we do PE alongside of DBT. And so we have kids who are working on addressing their interpersonal challenges and emotional dysregulation alongside dealing with the trauma therapy that they're also engaging in. One of the things we have to think about is identifying what is our goal here? What is the actual target trauma memory that we're focusing on? And why are we doing that, right? We don't want to just do trauma therapy for the sake of doing trauma therapy, but what is the treatment goal related to? How are we ensuring that this process is going to lead to some sort of outcome for this client that they are not only bought into, they're motivated to engage in, and that's going to generate some response to their life, right? And that's where the client's engagement, the client's motivation is 100% going to be the driving force behind conducting prolonged exposure, but conducting effective prolonged exposure. Because if they don't understand why they're doing it, then they're not going to do it. And they're going to be like, that's too hard. No, thank you. Because it is hard, right? And then next up, I think, is is family involvement and support and mandated reporting. These are huge considerations we want to talk about when it comes to doing trauma work with minors. So the family involvement, it's kind of a double-sided coin, right? One side of that coin, family involvement is always going to increase positive outcomes, right? If a kid can talk to their parents, they can have the support, they can have a safe space to share what they've experienced, they're going to be more motivated, more engaged, and feel safe to do this work, right? And at the same time, we need to understand, if a parent is a perpetrator or if a parent is maybe not as supportive of this young person doing the treatment, how do we address those things? And how do we get our parents educated on trauma and prolonged exposure or trauma therapy in general to ensure that they can be as effective of a support as possible? We want to make sure that we're maintaining confidentiality of our clients to the best of our ability, right? And we need to make sure that we find ways to include the parents. So a lot of times what that looks like for us is encouraging the client to, again, at their own direction and motivation, to share on their trauma with their parents. Maybe that's not all of the trauma, maybe that's pieces of it, but how do we build those bridges and gaps that are existing in their lives by having their parents be more of a support system for them? But it may also be things that there are existing safety concerns that also need to be addressed, and we need to get the parents involved in, right? And that is also where mandated reporting can come into. As clinicians working with minors, we are mandated reporters, meaning that we do have to report any instance of abuse, neglect, all the things. And so that can be really tricky when we're talking about, hey, I want you to trust me and I want you to know this is a safe place and we're going to do this work. And then you tell me this thing and I have to report it, right? And so it's really, really important when we talk about informed consent and we talk about education that we are starting with these conversations about what mandating reporting means and what that looks like. We are very transparent about mandated reporting and the prolonged exposure that we do here with our clients, because a lot of times a child may be sharing with us that they have been sexually assaulted or they have been abused by somebody, and that has caused trauma and led to PTSD symptoms. And so that is something that we have a conversation about, and that is not something that we deter treatment on as a result of. However, it just creates an opportunity for conversation. And then a note on maturity. We work with teens. Adolescents are immature. There's going to be nonsense. There's going to be silliness. And it's important to look at age appropriateness development as behaviors as age appropriate or developmentally appropriate, or is this avoidance? And sometimes they can be both. And so that's something we want to look at too, is if it is age appropriate, how can we develop tools to address that with the patient? And then how can we utilize that rapport building process to know the difference between the two? We don't want to delete treatment to build rapport because that's a form of avoidance in itself. We can do that alongside of the process, and PE is built in such a way to allow that to happen. And constantly building, connecting this client back to their goals. These young people can be so insightful and so self-aware about how their trauma has impacted them. And that's the goal of this work here, is to help to remind them that they want to get their life back from PTSD, and they want to be able to do the things that air quote normal teenagers are doing, and their PTSD is preventing that. So they may be immature, there may be silliness, however, we can still work with that. And we can also allow PE to be a pleasurable experience by developing positive rapport and having a safe place to be open and silly and fun sometimes, while also doing hard work. And that lightheartedness is really appropriate.
Right.
And the last thing is, I'm sorry, go ahead.
Okay.
I was just gonna say, I'm a very much elephant in the room type of person. It's really appropriate and to acknowledge that PE is not fun. It is not going to be a good time. It's hard. However, it is extremely valuable to them and it will create results if they stick with it. And so creating a space for them to acknowledge that it's not fun. Our clients will literally tell us, well, that was terrible, but I'm glad I did it, right? And that is important for them to be able to acknowledge that, because that is a component of the healing process.
Awesome. Okay, I'm gonna give Caitlin a break and we're gonna talk about prevention, but we're also gonna zoom through some of this. We've talked about some of this already, But we also want to make sure to leave time to get to your questions that I know are probably coming in that Molly will help us get through. Um, so what I want to emphasize is that following trauma, most are resilient. So remember that, right? I think there is a desire to want to do something. If there's a corporation involved, right, there's also a desire to want to do something to mitigate liability. Most people are resilient, and that's important to remember. And there are different models of resilience and prevention, whether it's using strengths that we have and are building strengths with others, or exercising, finding meaning making. There are lots of good resilience models out there. We're talking about the prevention of trauma, right? Which we're not focusing a lot on here. There's the prevention triangle, right? So primary prevention is not making sure trauma doesn't happen. So that is teaching kids about boundaries, safety, asking for help, finding safe adults. If someone has been traumatized, right, it's talking about don't do these things to other people, right? Just because it happened to you, right? That can be harder with little kids. And then, depending on parenting and depending on where they are, it can come to fruition in teenage years. But stopping that cycle. Secondary prevention is preventing negative things from happening after trauma does happen. So this is providing intervention sooner rather than later, right? So having it so that we're screening kids after something happens, so that they're not waiting 12 years to get treatment, right? So that they can get treatment and get on with their life. We want to create a safe space. So we want kids to seek out support, but also recognize a lot of these kids that are under Caitlin's clinic, they don't want their parents to know, right? So there's this very careful balance that you have to work with of, yes, we have to have parental consent. Yes, there's some things that have to be mandated reported, but they also want to make sure that there is safety, that they can disclose things to process it. And we're being transparent of what that balance is, so that there's nothing left unturned if it needs to be turned. Also normalizing the conversations. We also use very specific language. So we're not using euphemisms for our genitalia. We're calling it a penis, we're calling it a vulva. We are normalizing that you can have conversations about these things, and normalizing the impacts that trauma has as something that can be talked about and that we're going to help kids with. And providing support. That's different for each person. That can be resources, that can be guidance, that can be validation that this is harder, this is not fun. That can be, here are some resources for your parents. We just had parents this week that freaked out because their kid freaked out. So how do we provide that and make it a better support for our supports to help our kids? And then there are support groups, especially around traumatic loss and grief. There are support groups that can be used. A trusted adult is really important. There is a lot of theories talking about why this is important in the bidirectional impact of environment. This can be had through church, school, sports, and you want to define objective safety and what might be signs that a person or place is not safe as you're going through it and helping define, because even if they are older, those lines can be blurred if they've been groomed or something. And we're going back to Darcy, just because someone works at a school doesn't mean they're a safe person, right? So we often have these heuristics that a church, a place of worship, a school, a treatment center, everyone's good if they work in these good places, but not being on guard all the time in a PTSD like way. But how do we reason? And then Caitlin can take us home talking about DBT skills for trauma.
Yeah, absolutely. A part of what we want to encourage is that, yes, prolonged exposure, yes, TFCBT, and other resources are wonderful modalities. However, we want to make sure we can leave room for how do you create intervention or support someone, whether you're a clinician or not, who are struggling maybe with trauma-related symptoms, whether that's emotional dysregulation, whether that's the self-harm, the avoidance, the isolation, knowing some basic skills, and these are a few that are wonderful for distress tolerance, can be really great tools to just kind of add to your toolbox. And so I'm a huge proponent of ensuring that people have a takeaway too. We've provided a lot of information, but there's also an aspect of like, you don't have to be a PE trained therapist to be able to acknowledge that someone is struggling and that something has to be done there and in the moment. In addition, so those are the DBT ones: wise mind accepts, distress tolerance improve, and then distress tolerance tip skills as well. All things that we can train people to do to help people to engage in the feeling and the experience they're having in the moment versus engaging in avoidance. And to that same kind of token, we also can utilize some CBT coping strategies, which again, PE is a form of CBT, is all a form of learning. How do we help them to identify how those thoughts and feelings are a huge trigger for some avoidance? So looking at things like the TOM skill, which is again, a very basic changing problematic thoughts skill. And then the 3 C's of cognitive behavioral therapy, check, catch, and change, to be able to help people identify how some of those intrusive thoughts, those negative thoughts, those unsafe thoughts are leading to some really unsafe behaviors and avoidance, again, that is showing up within their life as a result of their trauma. So a piece of the prevention is also going to be making sure that we're educated with skills and tools to be able to intervene and help someone who may be struggling before they can actually get to the trauma therapy that maybe they do need down the road. All right. So that is all of the information that we have. I know it was just a little bit, and we are so excited to get to some of the questions. But before we do that, we wanted to take a moment to share that we will be, while we are primarily a residential and day treatment program, we are going to start offering outpatient groups here at our adolescent campus of Skyland Trail. This will be starting this late this summer. So we are formalizing that process and getting everyone signed up. And so we wanted to share that information. We're doing an anxiety-based group for adolescents, as well as a parenting group that is going to have both clinical and support components to help parents to support their adolescents as effectively as possible. So we'd love for you guys to participate, and we put that information here if you're interested.